set. I think that's it. We good?
Yeah, good.
Yep.
Okay. It's a pleasure to be here, and St. Mary's Hospital will be one of our best collection sites for ethnically diverse donations. So in the course of this talk, I'll tell you a little more about what are the critical things to cord blood banking. So the objectives is we'll talk about the umbilical cord blood as a source of stem cells, the options for cord blood after delivery, characteristics of different models for umbilical cord blood banking, and issues related to donor recruitment, consent, collection, processing, and storage, and utility of cord blood in hematopoietic stem cell transplantation, and potential additional uses of cord blood for regenerative medicine. So a little bit about stem cells, and I'm sure you've heard about this at some other talks. So the critical thing about stem cells, or sometimes also known as progenitor cells, is that they're able to perform self-renewal, which means that the stem cell is able to give rise to a daughter cell or daughter cells that are identical to it. And the other is differentiation. So the stem cells are also able to give rise to multiple different types of progeny that eventually can form all these different tissues. So on this slide, you have different types of stem cells, some called our totipotent stem cell, and the totipotent stem cell is a fertilized oocyte. The pluripotent stem cells are so-called embryonic stem cells, and then you have blood stem cells, for example. So on this slide, I want to illustrate the difference between so-called embryonic stem cells and somatic stem cells. So embryonic stem cells are derived from the embryo. They're able to self-renew, and they're able to give rise to tissues of all three germ layers, I mean endoderm, mesoderm, and ectoderm. The somatic stem cells are so-called adult stem cells, which are also able to self-renew, but are able to give rise to a limited range of tissues. For example, you would have a hematopoietic stem cell, which is able to give rise to blood cells mostly. So how do we regard cord blood as a source of stem cells? So the most important stem cells that are present in cord blood, at least for now, are hematopoietic stem and progenitor cells. It is the most recently identified source of hematopoietic progenitor cells, and the first human sibling antigen match umbilical cord blood transplant was performed in 1988 in France for Fanconi anemia. And 20 years later, the recipient is still alive and has a very good continued donor reconstitution. There have been over 600,000 umbilical cord blood units stored for transplantation worldwide, and over 30,000 of umbilical cord blood transplants have been performed. So where do hematopoietic progenitor cells in the cord blood come from? If we look at the development of hematopoiesis in the human, the hematopoiesis initially originates in yolk sac, and however, that first wave of hematopoiesis kind of disappears, and then the second wave comes from this region called AGM, aorta gonadomesonephros region, and then subsequently the cells move from there to the fetal liver and to the placenta, and then eventually towards the end of gestation they start moving into the bone marrow. However, the tricky thing is that we don't exactly know where the cells that are found in cord blood come from, and likely are mostly from placenta and fetal liver, and some from bone marrow, because none of these sites where the hematopoiesis occurs are fixed sites at that stage in development, and probably cells flux between the multiple sites. So what other cell types of interest are present in cord blood? So there's something called unrestricted somatic stem cells. A lot of these are terms that are derived by researchers applying different so-called differentiation methods. So they seem to think that there are cells that have slightly wider differentiation potential, and that probably is because these cells are pretty immature at that stage of development. So if pushed in vitro in the lab, they probably can form other cell types other than just a hematopoietic or endothelial, but they wouldn't normally do that in the body under physiological conditions. There are clearly something called mesenchymal stroma cells, endothelial colony-forming cells, and more recently, people started looking into presence of something called regulatory T cells. And these are cells that are very important in immunomodulation. So what happens, what are the options for umbilical cord blood after delivery? So it's abundant resource. There's about 4 million births per year in the U.S. So the expectant parents may choose to donate to the public cord blood bank, to a private, or also now known as family cord blood bank. They can donate for research, or it can be discarded as a medical waste. So the first umbilical cord blood bank was established by Dr. Broxmeyer at University of Indiana, and this bank provided the graft for the historic 1988 umbilical cord blood transplant. Subsequently, Dr. Rubenstein established a bank in New York, 1993 in Düsseldorf, and 1995 in Milan and here in St. Louis. Reports, and all of these are, I'm talking about public cord blood banks. Reports indicate that there are more than 650,000 unrelated units banked globally in 160 facilities. Interestingly, majority of bone marrow transplantation in Japan is performed from cord blood. And there's nearly 30,000 unrelated umbilical cord blood transplants performed to date. And in 2012, the World Marrow Association said that just in 2012, about 4,100 products were shipped in 46 different countries for transplantation. So what are some characteristics of public umbilical cord blood banking? It recruits mothers to contribute to the inventory available to use for use to any patient with demonstrated clinical need. There is no cost to the donor, and the primary motivation for donation is to help a patient in need of transplantation. It requires testing for infectious diseases, and it's subject to stringent regulations for good manufacturing practices. An interesting article was published in 2012 in the Journal of Transfusion, and the title of it was Awareness and Acceptance of Public Cord Blood Banking Among Practicing Obstetricians in the U.S. So they've compared the obstetricians affiliated with academic medical centers versus non-affiliated, and they found out that if the obstetricians are not affiliated, then basically there's a smaller percentage of them that are familiar with umbilical cord blood banking for transplant, as opposed to if the obstetrician was affiliated with the academic medical center. So in here, they gave them a survey and says percentage of respondents who agree or strongly agree with statements on cord blood banking with references provided. So they provided references and asked them a question, and you can see that here there is a statistically significant difference between affiliated and non-affiliated in the question, cord blood is especially useful for patients who need a transplant quickly. So in this table says mean percentage of disposition of cord blood after delivery. So you can see that in the affiliated medical centers, there's a statistically significant difference in the number of units that are amount of cord blood that is discarded. So if the obstetrician is in academic medical center, the chance of units being discarded is 58% versus non-affiliated is 82%. And cord blood collected for donation to public cord blood bank, if affiliated, at 26%, non-affiliated 5%. So it pretty much shows that the obstetricians affiliated with academic medical centers, where also probably transplant services exist, are much better informed about the potential uses of cord blood than have probably lectures like this to tell them what the current state of the field is. What is the family umbilical cord blood banking? So it's a private storage for family's own use. Different banks charge different fees. I don't exactly know. I think some of these fees have come down lately, but used to be $2,000 initially and $125 yearly. Is essentially promoted as biological insurance for future needs. There is also additional storage of biological tissue that is offered. So a few of the largest banks now offer to store either cord tissue or mesenchymal stromal cells from cord tissue. So ViaCord stores the cells, and the cord blood registry stores a little chopped up umbilical cord. And I'm not really sure who stores the placenta tissue, but I think it's also offered by some banks. Usually infectious disease testing is not required, and that's mainly because it's for autologous use, theoretical autologous use. There's minimal regulations since future use not based on disease, and also because the private banks are heavily lobbying with the Congress to keep the FDA out of their doorstep. The two of the largest private banks in U.S. have recently reported storing the cord blood stem cells of 700,000 newborns, and each of them having distributed approximately 250 products for traditional transplantation and regenerative applications. In this article published by Joanne Kurtzberg from Duke, you can actually see what they tried to compare is the inventory characteristics or quality of public banks versus private banks. So on this first slide, essentially you see, it's a little hard to see, it's the collection cord volume. And this is the total nucleated cell count. This is the CD34, which are hematopoietic progenitor cells counts, and this is total nucleated cell count, not compared to the multiple banks, but compared to the Carolinas cord blood bank, which is a Duke's public bank. And so the blue line is really the private bank, the red line is the public. So you can see in pretty much all of these cases that the collection volumes are higher, the units are larger, much larger that to the Duke's inventory. So in general, the inventory of a public bank and a private bank are quite different. And that means, as you're going to see later about the transplantation, it might pose a problem in future use of the units because they're relatively small. Essentially, as you will be able to tell, we reject a significant proportion of the units that we receive, and we only bank 10 to 15% of the units that are largest and the highest quality. The private banks would obviously have to bank every and any unit, regardless of its size. So the quality of the unit for potential future use may be in question. So how does the recruitment for cord blood donation occur? So it's a different setting from traditional blood donor recruitment, most importantly because it's a single opportunity. It's usually through obstetric physician offices or prenatal classes. What should be provided is the name of the bank, the parent holding institution, the potential medical uses of the cord blood, experience of the bank in providing cord blood for medical use, description of the donation, the risk of the donation to the mother and the fetus, the test to be performed on the cord blood and the mother, any costs that are associated for private banks, and whether the unit will be available for use by the donating family. So we do have a little bit of a issue with the last one, and that's just because we recently had a case where a family has donated a unit to the public bank, and maybe about 10 years later, the family, once the unit was picked for potential transplant, what we do something called follow-up phone calls. So we call the family and basically investigate if there was any problem with the baby, as the baby now became probably a child, and if there are any diseases or genetic issues. And at that time, the parents were requesting that the unit is now transferred back from the public bank to the private inventory. And different banks handle this different way. So in some cases, what we've allowed essentially for the unit to be transferred to the private inventory, but our consent, which you also have it here, basically states that if there is a clinical need for a person to receive their own unit, if a new application has been developed, then they will just demonstrate the clinical need, that the unit will be given to that person. So our general rule is that whoever has the highest clinical need at the moment will get the unit. If that is the person, the child who donated a unit, then it will be that child. Otherwise, it's going to, for example, a patient with leukemia. So the consent, basically the cord blood belongs to the newborn. However, the consent is obtained from the mother because she's available to give a consent, and because she also has to consent to infectious disease marker testing. The consent from the father is not necessary, and some studies have actually found that it doesn't add significantly to the safety of the collected unit. Ideally, this should be the prenatal consent before the mother is in active labor. However, different banks have different practices, and some have allowed a mini consent, which is just a consent for collection that happens like at the early stages of labor, and then the decision to final disposition of the unit, if it will be left for banking, would be obtained after the delivery. However, the decision to obtain consent rests with the obstetric staff. The abbreviated consent, as I said, is possible to authorize collection. Full consent can follow. However, the cord blood cannot be collected in utero unless consent is obtained. So because our collections here are in utero collections, essentially the consent must happen before the unit is collected. So the Foundation for Accreditation of Cell Therapy, which accredits all transplant services and cell processing facilities, requires now the consent must be, at least a consent must be available, collection consent must be available prior to collection of each unit. So the previous practices of let's just, and one of the biggest banks had that practice, and let's just collect a unit and we won't bother the mom at this time, but once she delivers, we'll come talk to her, is no longer an acceptable practice. So collection, and this is probably, this is your area. In utero collection, obviously obstetrician, nurse, or midwife performed. It is not performed if the well-being of either the newborn or the mother is in question. The care should be taken to minimize contamination. And so what we do in the bank, basically we, obviously all of the units are going for microbial testing, and if there's a microbial contamination, what we used to do is we used to send the letters to the collecting obstetrician and tell them, hey, this unit got contaminated. But I think we changed that practice lately, so what we do now, we follow trends. So if we see that any of the collectors significantly increase in frequency of contamination compared to the other ones, since we have about 500 obstetricians in St. Louis area that collect for us, we send them a letter. So we don't bother physicians as we used to. Essentially, it's not useful to know that every time there's some sort of a microbial contamination to get a letter. So the initial training period is required for obstetric practices, and several studies indicate that larger volumes and greater nucleated counts can be obtained by in utero collections.
What percent of units are contaminated?
Less than like 1%. So ex utero collection, what this one allows is the standardization of collection with limited personnel. So some banks have an actual collection staff on site and do ex utero collections. However, because the cord blood is beginning to clot, that seemed to have presented problems for processing after collection. So, and this clotting may also reduce nucleated cell counts because it traps the white cells in the clot. So per federal regulations, and this is the Code of Federal Regulations, what we are required to do is to minimize transmission of relevant communicable disease agents in the cord blood. We must obtain health history and medical evaluation, and specifically we must look into infection exposures and genetic history. The donor testing needs to be obtained within 7 days from the delivery. And essentially this donor testing, and this is another issue that we are experiencing a little bit, is that donor testing is different from clinical infectious disease testing. So when moms go for prenatal testing, they get a patient test, hepatitis B surface antigen, and so on. What we use is we use donor testing, which is designed for screening purposes. So they might be tests that are positive in our screening tests that don't turn positive in the regular prenatal screening. And this is what we do now is we notify, obviously, obstetricians, and we notify the patient. And we recently, in the past several months, we had a couple of cases. One case was interesting that the mom had negative hepatitis B surface antigen testing and everything was fine. But what we also do, we do testing called hepatitis B core antigen testing, which is antibody to core antigen, which is more sensitive and it's prone to give false positive results. However, this reflects to something called nucleic acid testing, where we tested hepatitis B virus nucleic acid, and that was positive. So hepatitis B surface antigen was negative, hepatitis B virus nucleic testing was positive. And the question was, what happened? The patient was of an Asian descent, and apparently the hepatitis B surface antigen testing does not pick up Asian subtypes really well. So she had a chronic hepatitis B infection, which wasn't picked up on a regular screen. So I think in general, just like in a blood donation, there's benefit to infectious disease testing with the blood donation. We were, the pediatrician and the obstetricians were kind of communicating to, see if the baby is got infected and so on. So as I said, the cord blood unit must be safe for clinical use. The history is not obtained from the donor. However, and that's the main issue about the cord blood use of cord blood units for transplantation, and that is the donor has not lived long enough to manifest disease, making his or her cells unsuitable for transplantation. There's a universal health history questionnaire is used, similar to the one used for blood donation. And as I said, medical history must be obtained within 7 days, either by hospital staff or the bank staff. Medical records are reviewed for maternal fever for a long time after rupture of membranes, use of antibiotics, genetic diseases, disorders of hematopoiesis, malignancy, and autoimmune diseases. So any of these, majority of malignancies, for example, would disqualify the unit, like basal cell carcinoma sometime in the history that was just removed, wasn't treated with any medications, would not disqualify. But for example, a testicular cancer of the father treated with chemotherapy would disqualify the unit. Autoimmune diseases, a very mild Crohn's disease that was just not treated with severe, immunosuppressive therapy would be fine, but anything treated with, strong steroids or anything more than that would disqualify unit for transplantation. So additional health history evaluation is also performed at confirmatory typing. So once the transplant center requests the unit for transplantation, then, as I said, we contact the mom or in some cases, the father again, and ask them if there were any other medical problems that happened with the baby or with the child since the donation.
Dr. Barrick, in terms of use of antibiotics, is it just short-term use of antibiotics at delivery, or is it?
Yeah. So FDA had a problem with the use of antibiotics. The problem was they stated that the usage of antibiotics masks our ability to test microbial contamination of the units. And one of the ways we get around it is that microbial testing we use uses these blood culture bottles that have resins that absorb antibiotics. But still, I think there's a concern in the field that there might be microorganisms in there that are covered by the.
A good portion of our patients are on GBS prophylaxis.
Yes, so we know that, and so far we haven't had a single problem of more than 2,000 transplants, and we use, as I said, antibiotic absorbing media. So the donor testing, as I said, laboratory testing is similar to laboratory testing for whole blood donation. Tests are performed on the mother's blood, which basically would be the main source of infection. And it also helps because because of the amount of blood needed for testing, it preserves the cord blood amount for subsequent use. Hemoglobin electrophoresis is performed. Generally, any hemoglobinopathy traits are acceptable. Homozygous hemoglobinopathies are not. Umbilical cord blood units selected for transplantation of patient with an inherited disease also should be tested whenever possible for specific disease. So, for example, a cord blood is frequently used for transplantation in Krabbe's disease, which is galactosylceramidase deficiency. So it is required that we test the unit for the normal function of the enzyme prior to transplantation. So processing of, once the umbilical cord blood is collected, for example here, basically it's undergoing processing, and the processing is to minimize storage space for frozen products and to optimize freezing by allowing uniform freezing and rapid thawing. It also removes red cells. So red cells have shown to be pretty good source of adverse events at the time of transplantation. So the more red cells are removed, the better. Processing can be performed either using manual methods, something called head of starch or prepicide, or the automated methods, and these are the two. So basically, the cord blood is mixed with sedimenting agent. Plasma rich with nucleated cells is obtained. Centrifugation uses density gradient to form a layer rich in nucleated cells, and that's generally called buffy coat. And the buffy coat is retained and excess plasma was removed. So the cryopreservation is also a tricky portion of the processing. It basically is there to prevent cellular dehydration and ice crystal formation, so we need to pay attention to that. And therefore, the cooling rate needs to be at 1 degree per minute. We use a cryoprotectant called dimethyl sulfoxide, which is also one of the major causes of adverse events in transplant recipients subsequently, but cannot be avoided. So the units are stored in liquid nitrogen at -150. And so far, what we were able to observe is that units that are stored for over 20 years have retained their viability and proliferative function. So FDA is currently or recently started to change the view of cord blood products. And now, bear in mind, everything I'm saying now is about cord blood products from public banks. Because these cord blood products are used for allogeneic, in allogeneic cases, so for people other than from the ones from whom the cord blood has been obtained, therefore FDA has classified this as a biologic drug. Biologic drugs are regulated under current good manufacturing practice rules and good tissue practice rules. And what this means that FDA is trying to turn cord blood and similar cellular therapies into sort of pharmaceutical manufacturing. So just like now, if you take a bottle of Aleve, you're going to see a lot number on a bottle. And if something goes wrong with the, if there's an adverse event upon taking a medication, then you call the company and say, this was the lot involved. What they would like us to do is to have each cord be a lot. And so as opposed to the lot of the pharmaceutical drug being 100,000 pills, a lot of cord blood is 1 unit. And so if this helps FDA track adverse events. And the only little problem that we have is that unfortunately we can't sterilize the cord blood as we could sterilize a chemical. So we rely on something called aseptic processing. So the final guidance was published in 2009, and cord blood was really the first cellular therapy that FDA has regulated in this way. And they stated at that time that within 2 years, all public cord blood banks in U.S. have to have a license for pharmaceutical manufacturing. And so far, this is now, 4 years later, there's only 5 banks that have been approved. And in the process of enforcing this, two banks have been closed, and there'll be more closures. Essentially, the major problem with that is that, let's say, if you have a medication, if you're one of these, let's say, orphan drug manufacturers, you can charge hundreds of $1,000s for a medication, and unfortunately, we can't do that with cord blood. So enforcing the same rules has caused some banks to be non-profitable and to close down. So let me talk about the need for cord blood transplantation. Basically, there are more than 12,000 patients in the U.S. are diagnosed with life-threatening diseases such as leukemia and lymphoma each year. So of these, the patients who need a transplant, about 70% of these patients will not have a matched donor in their family. Apparently, the reason being is the American families are shrinking down, so unlikely that these things will get better. So the major registry that is in the U.S. called Be the Match Registry, or also known as National Marrow Donor Program, is the world's largest and most diverse registry. It contains 10.5 million potential donors and about 185,000 available cord blood units. In 2012, more than 14,000 U.S. and international searches have been done through this registry, and more than 5,800 patients went on to receive a bone marrow transplant. So what is interesting is that depending on your racial status, you have higher or lower likelihood of actually getting a match through the registry. So if you're a Caucasian, you have 93% of finding a match. If you're an African American, you have 66% of finding a match. And that's mainly because the African American population, because existed in Africa for 200,000 years before going to Europe, migrating to Europe, which Europeans are only about 40,000 years ago. So Europeans have much more shallow gene pool than African Americans, therefore it's much harder to find a match for a minority. So this is where the Congress stepped in with something called Stem Cell Therapeutic and Research Act in 2005, signed by President Bush, and established a national umbilical cord blood program under something called C.W. Bill Young Cell Transplantation Program. And it provided $79 million for funding of centralized registry, which is this National Marrow Donor Program, an oversight board, a patient advocacy unit, outcomes registry, which is also called Center for International Bone Marrow Transplant Research, and for cord blood banks. So what Congress required at that time is that within 3 years that 150,000 high-quality units, mostly from minorities, are collected and put in a national inventory. Unfortunately, this is going a lot slower than projected, mostly because we're not requiring just any units, but it's minority units. So if you look at the registry, it has grown a lot since 2000, and now nearly 185,000 units. However, not only still a smaller proportion of them from minorities. So let me talk a little bit about progenitor cells in the cord blood. So the stem cell compartment in the cord blood is less mature than in the adult. These cells have a higher proliferative and self-renewing capacity than adult marrow cells. The frequency of hematopoietic stem cells is higher in cord blood than in the bone marrow, and it can be stored cryopreserved for over 20 years with efficient recovery. There's an extensive engraftment capacity which exceeds that of the bone marrow at least in studies that were performed in mice. And however, there's a limited number of hematopoietic progenitor cells in each cord unit. And so this is the drawback. The good side is that there's so-called immune tolerance with cord blood transplants. So what it means is that if you were to do an adult bone marrow transplantation with a bone marrow or apheresis collected peripheral stem cells, what's the standard now is to look for 8 out of 8 HLA match. Now, because of immune tolerance, the cord blood can be matched with 4 out of 6 match. So there's a good decreased incidence of graft-versus-host disease despite less stringent HLA matching requirements, which means that we're a lot more flexible in matching people like minorities with cord blood units for transplant. So what are the advantages of cord blood for unrelated hematopoietic stem cell transplantation? As I said, there is an expanded donor pool, and because there's an increased representation of ethnic minorities. One of the problems with the adult registries is that it has 10.5 million donors. So the way these donors come about in a registry, for example, a relative has a leukemia, and then family decides that they're going to go and try to ask all their friends and relatives to donate for that person. So they go and sign up on a registry. So let's say for a person with leukemia, you have 20 family members and friends. However, 5 years later, they stay on the registry. Somebody else gets a leukemia, and let's say one of them is a match, and then the registry will call them, and they said, there's a person in South Dakota that needs a transplant, and they said, well, this is for our friend and relative, but yeah, I'm not really available. So what this is called donor attrition. So donor attrition is basically they change their mind. And apparently in minority populations, the donor attrition is a lot higher than in let's say, Caucasian populations. So there's about 60% donor attrition for African Americans. There's only 40% donor attrition for Caucasians. So what it means is that we need another source of cells to be able to afford transplantation to minority patients. Cord blood is also much more easy to procure. In a sense, it is in the tank. It is tested prior to storage for infectious disease, HLA type, and cell dose. And essentially, when the patient needs the transplant, they can just call the bank, and the unit can be mobilized from the tank. So, as I said, lack of donor attrition. There's a lower incidence of graft versus host disease, so this has been reported to be lower in both adults and children. So safety of donor, so umbilical cord blood collection does not put the mother or newborn at risk. In addition, there's a reduced likelihood of transmitting infectious disease like cytomegalovirus from donor to the recipient.
Do they ever think that there'll be ways that stem cells can help people who do have graft versus host disease?
Yes, so these are the T regulatory cells. So not the hematopoietic stem cells in their native state, but Tregs. There's a study at the University of Minnesota right now to infuse T regulatory cells into lessen the GVHD. Unfortunately, there are some limitations, and there's an increased risk of graft failure because the cord blood contains limited number of hematopoietic progenitors. Single unit frequently does not contain sufficient hematopoietic progenitor cells to allow for reconstitution of the bone marrow. And hence, if you see Vicky around and Vicky pesters you with, we need larger units, that's pretty much the reason for this. So there's also something called delayed immune reconstitution. And what that is, if you do a traditional bone marrow transplantation, there's time to engraftment, immediate neutropenic period is about 11 to 12 days. With cord blood, this immediate neutropenic period is a lot longer, and the reason for that is that the cord itself contains fewer progenitors of the hematopoietic type than the bone marrow. So if you were to give somebody bone marrow, the progenitors circulate and protect the patient from infection in a pretty short period of time. The cord blood takes approximately 30 days for this to happen, and in this period, the patient has a significantly higher chance of actually succumbing to infection and dying. There's unavailability of the donor for additional donations. So sometimes in transplantation, patients are given something called donor lymphocyte infusion after transplant. So obviously we cannot go back to the cord blood donor and ask him or her for anything else. There's a possibility of transmitting undetected hematologic pathologies. So usually the units are transplanted within 5, 6, maybe 10 years from donation, which means the child is now up to 10 years old or maybe 12. So hasn't been enough time to show some sort of leukemic potential, and therefore, there's a slightly higher chance of developing those pathologies in the recipient. And the autoimmune disorders, There is some thought in the field that there's slightly higher chance of developing an autoimmune disorder later for the umbilical cord blood transplant recipient, but that hasn't been really well studied. So we don't know at this time how this will fare out. So if you look at the numbers, this is the adult transplantation, this is the pediatric transplantation. So from National Marrow Donor Program, this is the cord blood. So initially, cord blood was very popular in 2000s, was popular with pediatric transplants. The major problem with pediatric transplantation is graft versus host disease. You do not want a child to succumb to graft versus host disease after some sort of acute lymphoid leukemia. So bone marrow transplants are very popular in pediatric setting. And it was found that cord blood's ability to, or the result to have lower GVHD risks can actually supplant the bone marrow as a source of cells. In addition, these are kids, so being smaller, there's usually a good number of cells in each individual unit for transplantation. So when that happened, also the adult transplanters decided to try out the cord blood, and what happened is that, as you can see, the numbers are slightly less enthusiastic than in the pediatric setting. So sometime around this period in 2005, what was introduced is something called double cord blood transplantation. So majority of adult transplants now are done with 2 units, and so the 2 units are compatible to recipient and are compatible between each other. So what happens is if you follow these patients, you're going to see that in a transplant you see 1 unit predominates, then 6 months later the 2nd unit predominates, and it goes back. Is a very unusual interaction between the hematopoietic stem cells from unit 1, unit 2, and the recipient. If you look at the engraftment probability with different graft sources, essentially this is the 42-day probability of neutrophil recovery. Not to read all these numbers, essentially there's an 80% chance of neutrophil recovery within 42 days with cord blood, and there's 96% chance with peripherally collected hematopoietic cells. So cord blood being the slowest and hematopoietic peripherally collected cells being the fastest. Same thing applies to platelet recovery, cord blood being the slowest and the peripherally collected cells being the fastest. So this is what puts patients at the highest risk, and this is one of the concerns in the field now. So there's several approaches essentially at the largest transplant centers to try to bridge this period. So one of the approaches developed at Fred Hutchinson now in Seattle is to use cord blood to differentiate progenitor cells, which can be given to patients to speed up the engraftment. So you have a transplant with a unit of cord blood, and in the meantime you give them these pre-differentiated cells that are not necessarily matched, which then now with these cells you can kind of make a mini bone marrow out of a cord blood by combining the two products, and essentially you can bring down the engraftment time from 30 days to 12 days. So it would be equivalent to apheresis products. However, what's good about cord blood, if you take a look at the probabilities of leukemia-free survival, it's leukemia-free survival with cord blood is fairly good compared to one mismatch peripheral blood collected cells. So cord blood cells have, which is very important to us, cord blood has very good potential in fighting off the leukemia without causing as much GVHD as adult collected cells. So where do we stand now? If you go to clinicaltrials.gov and put cord blood, there's supposedly 867 clinical trials on cord blood. Various applications. There are applications in using cord blood in spinal cord injury repair, GVHD, transplantation, using mesenchymal cells from cord blood for different type of tissue repair. So it's a very active field of research to try to use this resource as well. And a little bit about the bank. was founded in 1995. It's a community program, operates in collaboration with more than 450 physicians at 29 hospitals in Missouri and 5 hospitals in Illinois and in Kansas City. There's have been more than 130,000 cord blood units donated. Out of these, 28,000 met banking criteria. And right on the map here, you can see where all the units have been exported for transplantation. And I think now 2,400 units have been distributed to treat patients with more than 80 different diseases. And with that, I want to thank you for helping us save lives.
Thank you very much.
Yes.
Is there any use for the plasma, the stem cells?
There, I've heard there is. Apparently, you know how in tissue cultures, in biological manufacturing, fetal bovine serum used to be used. Some places are trying to replace that with cord blood serum sort of thing. So I don't think it's very widely used, but it's an option to limit exposure to animal tissues in biological manufacturing.
And also, why is it that we're only able to use the, use the percentage-wise, 28,000 over 130,000? So when you do the cord blood, the like you said before, for private banking, they take anything.
Yes.
I mean, theoretically, the requirements for usage would be the same whether it's a cord blood, whether it's a public cord banking or private cord banking. So why is it that we can only use such as 20% of
Sure.
blood?
So the required total nucleated count for transplantation is 3 times 10 to the 7 per kilo of a patient. Each unit right now is about $35,000. So for the transplant, basically, if you don't have, which forces the transplant center to really look at the counts, and essentially for a good-sized adult, you need 2 units. So, and because cord blood is used in a setting where lower grade matches, so cord blood not being the primary choice for transplantation, you use it when all else fails. So you can't have a bone marrow donor, you can't have an apheresis donor, you go for cord blood. So in order not to risk, to minimize the risk of death within the first period of 30 days, the more cells you give, the shorter that period is going to be. So with actually our units, we've done a little clinical study. The time to engraftment is about 18 days. So the more cells you have in there, the faster will be the engraftment. So what the transplant centers do, they have a list of units. So the first thing they look at the grade match, and the second, or however, either the TNC or the grade match. So what they have, choice from New York, choice from St. Louis, choice from now Europe and so on. So they look and say, I have this 6 out of 6 match unit, but the total nucleated count is only 1.6 times 10 to the 7. However, I have this 5 out of 6 unit, and this is called art of transplantation. And the count is 2 times 10 to the 7. So I'm going to go with the 5 out of 6 because I have a space between 4 out of 6 and 6 out of 6. But I will go for a bigger unit. And then I might use a smaller one. So it's as I said, it's an art. But basically, the bigger the unit, the more likely the unit will be picked. And when we look at our inventory, you can actually see, I don't have that slide here, that all the largest units are constantly getting picked. And from years 1995 to 2005, our inventory now is like down to smallest units, which will likely, at this rate, probably never going to be used. Go ahead.
2 questions. One of them, the units that you don't use, are they used for anything else? And the second question is are there policies about using units from babies that have fatal disease, like a congenital anomaly, not genetic, that won't be around in 20 years, to ask them if they've developed any problem?
We actually got visited yesterday by the group called SHARE. I don't know if they're here. They're in St. Charles, and they're the counseling group for parents who have whose babies died at birth or were born dead, or if cord blood could be used. So I can tell you that basically we would have to heavily investigate why the death occurs and clearly document to the transplant center that death was absolutely unrelated to the any hematopoietic function, which in this day and age when all the genes are connected in some way, it's really difficult. So I have to tell you from working with transplant centers, convincing them that a unit from a donor who died 10, 12 years, unless it was an accident, will be low on their priority list for transplantation. It's just that there's so much we don't know about the actual function of stem cells that they would, and the availability of these units now. So there's 185,000 units in the inventory, that they will probably not choose that unit for transplantation. It will be a repeated event and eventually will never be used. We would have it in the inventory, but they'll look at it and they say no. What used to happen in bone marrow transplantation, even people with malaria used to be viable donors, and this was many years ago, that the number of sources, the number of donors have been limited, and the transplantation field hasn't advanced enough to fight off, to take care of GVHD and so on. These days, transplanters, because of all the availability of 10.5 million donors, haploidentical transplantation, cord blood transplantation, are very picky and choose only the grafts from the best source. So biggest grafts, highest grade match, most healthy donor, and things like that. Was there a second question? Sorry.
What do you use? Do you do anything with the units that don't meet criteria?
Well, the rest of the unit, for example, about 15-20% of the units that come from here are processed. The rest of the units that come from here go for research. So there's a number of researchers at WashU and actually outside of St. Louis that benefit from, we ship the units to them for research. So now these units that are in the tanks, eventually they might go for research, but as of now we haven't made a policy that, if the unit was from 1998 and is smaller than 1 times 10 to the 7, it's going to go for research. Eventually that might happen.
I was just thinking in terms of cases like anencephaly and things like that, where...
And that's what I told them yesterday. I said, knowing how things are, no one would want to transplant that unit, and I can understand them. I mean, we would probably have to do like cytogenetics, and in a lot of cases when this happens, I mean, cytogenetics will eventually be done, but we would have to do a very heavy investigation on what the genetic cause of the problem is to assure the transplanter that no hematopoiesis will be affected in the recipient subsequently. And I think it might, if it was like an amazingly large unit from a minority that the patient is dying from a leukemia, we have this request, we would definitely do it. But on a regular day-to-day basis, probably is better that not to have that unit in inventory.
The other question I had was on, certainly increasingly more of our patients are having babies who are biracial.
Mm-hmm.
So are they helpful, or is that less desirable than a uniracial baby? Or
No. No. So there was a study that said that ethnicity doesn't matter. What matters is the HLA. So the tissue typing, the more diverse the population, the better. So I would say those biracial babies are probably better in HLA diversity. Yes. From a transplant.
That's right. And I guess the other, you mentioned African Americans, but there are certainly a lot of other minorities in the States and around the world. Are there sort of Native Americans or Asian population where there are needs, or is that being met by the sort of Chinese and things like that?
So China has 5 or 6 banks now, and they don't share, and it's fine. It's a large enough country, but there's a little bit of politics, I think, in this, that each country likes to have. I mean, we in U.S. are very collaborative, and in a sense, our units are probably the highest quality, and we export a lot in Europe because we're really well organized, and the transplant centers believe into the units. So we don't get any units from China. In China, apparently, we listened to a talk by a researcher who said that China specifically in clinical studies did not want any units from the U.S. So, I don't think that's a medical decision. It's some sort of whatever. And Japanese, on the other hand, as I said, all their bone marrow transplants are with their own cord blood, and they feel strongly about not getting anything from the outside. And they have very well organized cord blood collection program. And again, that's a national policy. So a few countries have these national policies that if they have enough units, they can sustain them. Plus, Japanese people are slightly smaller size, so you can actually achieve a significant number of transplants. In U.S., you go to the population's size is slightly bigger, and just to put it mildly. So I think it creates a problem for transplantation.
So in the U.S., we may have, for someone who was Asian, for example, we may have a hard time getting a match.
It's probably more difficult, yeah. I think, interestingly, Hispanics have better chance of finding a match than African Americans. So right now, I think African American population is having biggest problems, and one of the problems with cord blood is also that the nucleated counts in African American units are smaller. Now, I don't know the actual reason for that, but they're just smaller. So I think one of the biggest advances that we could do, and we're trying to do, is to have cord blood transplantation for sickle cell disease, and that would be a major impact on in the African American population.
Is there anything that can be done to enhance the population of cells?
Yes. So just like there's the clinical trial in Seattle on bridging the first engraftment period, there's a clinical trial at Duke and Minnesota, and I think also in Hutchinson, about expanding the number of stem cells in the unit. So that should be a page turner for the cord blood transplant field. So basically, we were actually told by the head of the transplant in Minnesota, don't dump those little units, we'll use them. So eventually there might be a technology that in a couple of years that will promote expansion of number of stem cells, and even the smaller units will then be useful. So he said the preliminary results from a so-called Novartis trial are that smaller units will also be able to engraft just from a single unit to engraft a larger recipient.
You're talking post-collection. I'm thinking pre-collection. Is there anything that we could even sort of, giving folic acid or giving iron or giving,
stimulating cells to
somehow.
I met a researcher at a conference, and he claims he wants to use this solution to flush the placenta. So, that's the only one that I know of, but the problem would that be to actually show that these cells, which he's flushing away through the cord from placenta, are actually good for transplantation. It's a large endeavor. I'm not sure who would do that kind of clinical trial. But other than doing the longest collection that you can, which is probably the easiest way, I think that I haven't heard of anything else. I think the biggest problem in obstetric practices is that obviously physicians are very busy, so keeping extra minute in collection seems to be a difficult task. And that's why we're going to try in the next few months. We're going to have a meeting for obstetricians for St. Louis area to show them how important it is to get bigger units. The expansion technologies eventually will be coming, but still I can imagine that if you start with a larger unit, it will always be better than the smaller one, the expanded or not expanded. So I think collecting the most cord blood you can, and something that I specifically chose not to talk about because it is not my expertise and is delayed clamping, and that's yours. Yeah, so. Yes, so some places have a universal delayed clamping policy or starting to have, so that will have an impact on the size of the units and will probably decrease the percentage of bankable units. Well, it also apparently depends, it's how long it's delayed.
They do well in Minnesota.
Yeah, so I think we were just there and then they told us, so I don't know if it's 30 seconds versus 5 minutes. I mean, there's a span of time there that people will do. So I guess it's each center on their own. So we'll see. I don't think we're having very good collections in St. Louis area, so I don't think we have any major impact by that practice right now. Okay.
Well, thank you.
Thank you.
Good work.